Well, hi, everybody. Good afternoon, good morning, wherever you are in the country. Glad to have you with us. My name is Garrett Schmidt, and I'm the managing editor for VBC Exhibit Hall. So glad to have you with us for today's live webinar that is hosted by Roji Health Intelligence. And today's session is a part of a three-part series. This is part two. Don't worry, you won't be lost if you haven't heard part one, and we'll make sure to get you a link to where you can go watch that. But this is a three-part series. Today's is called, the series rather, is called How the CMS National Quality Strategy Can Guide Your Value-Based Care Journey. And so part two is called Using Innovation Center Models to Drive Efficient Specialty Care. And you're going to be able to hear from Dave, who I'll introduce in a moment. A few items of note before we get started. As usual, this is a traditional webinar format, so you don't need to worry about muting yourself or your microphone or turning off your camera or anything. That has been done for you. But we are going to have a time for some Q&A, so would love to hear from you at that time. So if you have a question at all for our speaker, uh, feel free to drop that into the, there's actually a space for questions on your attendee module. If you would drop it in there, we're going to get to as many of those as we can during the allotted time. If for some reason we don't get to yours or we run out of time or whatever, don't worry, someone will reach out via email and make sure that we answer your question. And finally, the session today is being recorded. So what's going to happen is when we're done, you'll receive an email from one of us, and it probably about an hour or so after we conclude, and there will be a link to where you can watch the session again, or download the slides, or share it with your colleagues, and we hope that you do. Yeah, and I'll remind you again of these things at the end. Okay, without further ado, let me introduce Mr. Dave Halpert. He is the Chief of Client Team with Roji Health Intelligence, and he is going to be our guide today. Welcome, Dave.
Thank you, Garrett. Good to be back. Um, good day, good morning, good afternoon, everybody, wherever you are. This is the second of our three-part series. So earlier this month, we looked at primary care and how the CMS National Quality Strategy and some of the CMMI models, the Innovation Center models, can bring primary care measurement beyond the total cost of care, that there are more metrics there that we can look at. And so today we're going to branch out and talk about how you can add efficient specialty care into the mix. A little bit about us. We are a value-based care strategy and technology company. That means we provide our clients with the tools and support that they need in order to measure and improve quality and cost metrics. Our tools highlight variations in care. We look at populations for targeted interventions based on a multitude of factors. And we've been a CMS qualified registry since 2008, which is the first year that CMS opened the door for third-party intermediaries like us to collect, aggregate data from our clients and then submit it on their behalf to CMS for models that were at that time PQRI, which later became PQRS and later MIPS, and also ACOs as well, particularly now with the APM Performance Pathway, or APP. We are able to report on electronic clinical quality measures and other clinical quality measures, and have been aggregating disparate sources of data for decades now, which is amazing to say. So you are in the right place if you are in an ACO and you're looking at evaluating affordability or trying to enhance savings. If you are a medical group that is interested in maintaining consistent revenues, one of the things that you'll see in a lot of the programs that we discuss is that they include a lot of upfront payments. And what we saw during the pandemic was that fee-for-service, depending on fee-for-service, really took a hit. And so this is, if you're interested in maintaining consistent revenues, this is a good presentation to be in on. Anyone to look at value-based care payments, like population-based payments or capitation, this is a good spot. And then finally, anyone who is negotiating contracts with private health plans that include risk features, this is going to be something that is going to help you along on that front as well. So, in terms of what we're going to cover today, I'll give us a brief recap of lessons learned and the national quality strategy from part one. Next, we'll move on to integrating specialty care. The first phase of that is looking at cross-cutting specialty care. So where can you sort of see the most value? Then we'll get into phase two, which is going to depend on your specific network and what sort of services that you typically provide. And then finally, creating a more cohesive network where we get out of those silos. We don't, where care is less fragmented, we bring everything together. So before we get into it, we're gonna play Name That Tune. Finally, my love of music and the amount of my brain that is devoted to song lyrics finally pays off. Which of these song lyrics best encapsulates your incorporation of specialist providers into your value-based care strategy? The future's so bright, I gotta wear shades. I'm working on a dream. No time left for you, or what's going on? Give a second there for people to vote.
All right, we've got the poll pulled up here, and it should be on your screen. So go ahead and take a vote here for which one encapsulates your incorporation of specialist providers into your value-based care strategy. And of course, this is anonymous. We're going to go ahead and share the results though pretty soon, and you'll be able to see where you stack among your colleagues. And we've still got a few results coming in here, so give it another 10 seconds or so. All right, I'm going to go ahead and close it out in 5, 4, 3, 2, and 1 and share the results.
All right. So it's looking like we are very hopeful. We are trying to get there, and we're not quite there yet. The future is not so bright that we're wearing shades, but we are working on it. There are a few of you who are feeling it a little bit more. They're either very focused on primary care already, or just keeping the doors open, and then there are some that really just are looking for a good place to start, and so that is fantastic. I like this polling question because all of these answers are whatever you pick, you're in the right place here. So let's dive into it. The
Very
first thing I want to do is recap where we left off. So for a bit of a refresher, over the last 10 years, the CMS Innovation Center has piloted dozens of value-based care models. Some of them have been more successful than others, obviously. And so for the next 10 years, they want to continue to develop programs and to account for several key lessons. And the big ones I've got here is that there needs to be a very focused pathway towards improving health equity. In order for meaningful transformation to occur, there's got to be more focus paid to health equity. Models need to be simplified. Anyone who has been in this business for a bit knows that some of the earlier models suffered from a lot of complexity, and also some of the previous models were, instead of complementing each other, they conflicted with each other, and so no one really knew which investment dollars were going to which program. Which rewards were coming from which program, which penalties were coming from which program. There needs to be, and CMS has recognized that investment is required in order to succeed under risk. There needs to be a bit of upfront investment. There's a lot of resources that you need to fund. The biggest one of those is going to be, well, not the biggest one, but the most important one is going to be figuring out a way how you to aggregate data, because without being able to aggregate data, you're not going to be able to see who needs what. Financial benchmarks previously were unclear, and there was also a selection bias. So with what I mean by the selection bias is that some of the models were mandatory, but many were not. And so the people who chose to participate in the voluntary models did so because they figured that they were in a good spot to succeed. And so there was a selection bias. And then finally, top-down dictation eventually leads to backsliding. So that's the other side. So if a a model comes from top down, if it is mandatory, well, that is a problem too once that model stops. The national quality strategy itself, beginning with the 2021, what they call the strategic refresh, and then in 2024, the quality in motion update is built on 4 key pillars, and each of those has 2 components apiece. So we've got the interoperability and scientific advancement. So we're talking about things like having data aggregation, the eventual incorporation of AI, and some of the other goodies. Outcomes and alignment, making sure the programs dovetail with each other and that there is a focus on the high priority outcomes. Equity and engagement speaks for itself, as does safety and resiliency, meaning that the healthcare system can continue to operate even in the face of challenges like pandemics, natural disasters, and any other sort of big big hits to the industry in general. When we talked about the primary care piece, we looked at four key components for success, and we'll see the same thing today when we look at bringing in specialty care. They don't necessarily need to go in order. Some of them are going to happen concurrently, but the 4 key ones are, first of all, investment in infrastructure, and that does need to come first, as I said, because you're going to need um, data aggregation tools to make it work. You're going to need to improve your data collection, identify disparities, look for things that you may not have been looking for previously. Going to want to be looking at all patients, not just patients who are involved in a narrow specific program. You want to be able to maintain a single high standard of care so that you can eventually get to that multi-payer alignment. All right, so as I've been not so subtly hinting, data aggregation is an absolute must-have. You need it to bring these solutions to life. And it's more than just quality reporting. We know that data aggregation is going to be critical for many, but for ACOs, once the web interface is completely sunset, there's going to be the need for ACOs, anyone with disparate data sources, to aggregate that data and submit it, being able to track one patient across the continuum of care. And so it's also important to remember, whoops, sorry about that. There we go. It is also important to remember that QRDAs are not comprehensive here. So even if your systems are able to produce QRDAs for reporting ECQMs, those are limited to specific quality measure values. And so that when you're looking at population health, those are not going to be sufficient to bring your program to fruition. So specialty care is a very broad topic, obviously. There are dozens of specialties out there. Where should you begin? And that should be where you can see the most bang for your buck, and that is cross-cutting specialty care. It's going to produce the most broad results. So if you're starting from primary care, it's that initial piece of that first sort of concentric circle of specialty care outside of that. The first thing that I want to call out is that specialty care does not equal excess cost. You're not, just because someone is seeing a specialist does not mean that the cost is excessive. A global value-based care initiative can't survive without efficient specialty care. The problem comes when the specialty care is fragmented or outside of the scope of the value-based care entity. Very challenging for people to be able to see what happens outside of their walls, particularly in an ACO when you do not find out until your set of claims files arrives. So you can expect that 40 to 60% of your total costs are going to be provided by specialists. And so what you need to do is to ensure that those specialty costs are coordinated. The challenge is collaborating with specialists to produce the optimal results. There is a lot, historically, a great deal of back and forth about who is responsible for what. And so the way that you need to get through that is to strategically apply your scarce resources like time, investment, and effort, and use data-driven models to create optimal and efficient care. So where should you start? The dollars don't tell the whole story. One expensive case should not dictate your development. So without an adequate sample size, I have a very loud dog who is currently sitting in her little crate, so she's not disturbing us here. But it's like when she chases her tail. If you're going after one expensive case, she's going to get her tail. I've seen it happen, but nothing really changes. 10 minutes later, she's chasing it again. And that's the same sort of principle here, is that if you have one high cost case, yes, you may find out what happened in that case and be able to address it, but there's going to be another high cost care case down the road unless you've looked more globally. And so the place where you can do the most good the most quickly is to look at disease progression. It's going to prevent excess utilization. It's going to directly improve quality measure results. So if you're talking about in the APP, hypertension, diabetes, and behavioral health too, it's going to directly impact those. And if you're in other programs, there are plenty of other quality measures that are going to be associated with these programs as well. It's the natural first step beyond primary care. Or it's going to be very easy then for you, once you start focusing on these, to identify the absence of these in your network. So one of the things that we can do is look at what we call notable emergency room visits. So our patients with chronic conditions driving costs through emergency department utilization. These are things that will help you identify right away whether or not patients um, are being coordinated appropriately. So if they are being sent to or if they are going to the emergency department for things related to chronic condition management, you know that they are sort of getting out of control and they need more effective management, or they might need to be referred to a specialist to keep them out of the emergency department. So having the ability to see that is key, particularly when you can drill down to practices and providers. So logical first steps in being able to get to this are to look at the CMMI programs that closely orbit primary care, where you can look at slowing disease progression and preventing some of those emergency department visits or hospitalizations that are associated with chronic conditions. There are three of them that I want to focus on today. The first is related to innovation in behavioral health. The next one is the Medicare Diabetes Prevention Program. And finally, kidney care choices. So starting with innovation in behavioral health, there's well-documented links, and I'm sure that you all have seen the studies too, between behavioral health and substance abuse disorder and their impacts on chronic conditions. And so what the purposes of this program are to screen and assess behavioral health and population health needs, including health-related social needs. And so by looking at behavioral health and population health conditions, adjusting plans outcomes are flatlining, and it's really based on ensuring that there is input from the beneficiary and whole person care. Again, this ties directly with the APP. One of the three measures that you're going to be looking at there is screening for depression and follow-up. So if you were looking at this program as a way to bring some of your specialty and mental health professionals into the fold, it's going to see value both for your patients immediately and then also obviously for some of the quality reporting down the line. Here is a visual of what you might want to see, looking at visits for, again, in the emergency room, what happened, what were the patients admitted to, or excuse me, what were the patients seen in the emergency department for, and was there follow-up after that? So you want to know, were the patients who have been seen, did they get some sort of follow-up, either virtually or perhaps from primary care? And that is one of those things that I know is very challenging for a lot of groups, is there is a limited amount of behavioral health availability. And there are still plenty of virtual options now. That's one of the things that did come out of the pandemic that were particularly useful, is the ability to incorporate virtual behavioral health visits, and that helps organizations a lot to be able to broaden that. The next one that I want to cover briefly is the Medicare Diabetes Prevention Program. It's Medicare has put out that type 2 diabetes affects more than a quarter of Americans aged 65 or older. $205 billion was spent on diabetes care for that group of Americans in 2022 alone. And obviously, it is a very, very costly and can have a great deal of impact down the line. 1 in 2 over the age of 65 have prediabetes, but only 1 in 7 know that they have prediabetes. And so the purpose of the Medicare Diabetes Prevention Program is it's a short-term program. It is data-driven based on BMI goals, supported by behavioral counseling, as discussed previously. So you can see how that this program is going to dovetail with the behavioral health program. Focusing on BMI is going to be able to see quick impacts. We're seeing that with hypertension as well, and so that's what the purpose of that program is. When you are looking at evaluating that, this is something that we're showing here is the patient population who has what we're calling persistent poor control of diabetes, and there is obesity with no nutritionist or dietitian visit. So we've got a couple of things that we can see here. The first is what percent of the overall population this affects, and then also what other comorbidities are involved here. And so you can see on the screen, patients are also predominantly have hypertension, and so the focusing on BMI is going to affect that as well, and COPD and heart failure. So what you need to do is you need to identify who these patients are that have high BMIs and intervene, and these interventions should be targeted. There are going to be different reasons that people may fall into this group, and so it's not just enough to say your BMI needs to be lower. There could be reasons for it. There could be things like patients need community support. They need family or caregiver support. There may be issues of food or housing insecurity, and these all need to be addressed. So the interventions need to be targeted and specific, and that goes back to the data collection piece I had mentioned previously about ensuring that you are collecting data on social determinants of health, health-related social needs, etc. And you need to be able to track that improvement over time. It's not just enough to be able to say that we are doing something. You need to be able to see if it's working. Otherwise, you're just sort of spinning your wheels. The next program is the Kidney Care Choices model. It's for patients with chronic kidney disease, and the goal is to put the brakes on it before it becomes end-stage renal disease and requires a lot of dialysis. Obviously, dialysis is very costly, and it is very challenging for patients, impacts quality of life. And so what we're trying to do with the Kidney Care Choices model is to improve the patient experience and reduce that total cost of care. The goal, again, is to prevent kidney failure, reduce dialysis rates, and also improve transplant access. Improving transplant access has been a common piece in a lot of the models that we're seeing come out. It was featured heavily in the CMS National Quality Conference earlier this spring, is access to transplants. The model provides upfront investment with risk options, and it varies by the track that you would like to participate in. But again, that upfront investment is very useful because it will help you invest in data aggregation methods and strategies where you can see who these patients are and what specifically is leading to some of these outcomes. Once you've accomplished that first concentric circle, you're into that specialty area. What you want to do is you want to branch out into something that is more specific, and that's going to mean episodes of care. So as you're incorporating episodes of care, we're looking at conditions and procedures that are to the and you want to examine where there are cost variations and be able to view that data. It's critical that the episodes be clinically focused. It's not That's one of the unfortunate side effects of some of the models out there, is that there is a focus on total cost of care, even though some of those costs really may not be appropriate when you're looking at some of those models. So within each episode, you can compare what services and what costs vary, and it needs to be something that you can control. They can reveal cost drivers and factors that appear both for quality and for discussion with providers and with patients as well. There are a few examples of episode-based care measurement in CMMI and then also in MIPS. For CMMI, the primary episode-based care measure models are what is referred to as BIPSI Advanced Bundled Payments for Care Improvement. The next is recently announced the Transforming Episode Accountability Model. And another very important one is the Enhancing Oncology Model. And I wanted to bring that one in because it is based on a chronic condition, but it also has an episode of care focus to it, and so it's worth showing that type of model as well. And then finally, in MIPS, the merit-based incentive payment system, there are cost measures that are episode-based. CMS has branched out very much from the initial two measures of cost, and I'll talk about some of those. So getting into BCPI Advanced, the rationale is that procedures and hospitalizations result in care fragmentation. So as you're having procedures done, it becomes almost incumbent on the patient to coordinate their own care with the primary care provider, and the goal here is to move responsibility for communication from patients to that BPCI participant. The goals are successful recovery, reduced readmissions and complications. It's measured based on total cost of care, and there are quality measures within that episode window. Now, this is the buyer beware part. Total cost of care does include all costs within that episode window, even if they are not necessarily clinically relevant. There is also an issue where different procedures are bundled together. So instead of, let's say, looking at a total knee replacement alone, the BPCI set for orthopedists includes several different types of procedures. And so that kind of loses clinical integrity. It's very difficult to figure out what is affecting costs when you're looking at so many things at once. And so what we want just one procedure at a time. So to identify variations, you need to have clinically relevant clinically relevant comparisons, and not just by procedure. There are different types of procedures. So there may be different categories, like is the procedure an open procedure, or is it an arthroscopic procedure? Is it trauma-based? So that as you are drilling down to practices, to providers, and finally individual episodes, you are looking specifically at what can be controlled and what may be useful down the line, as opposed to just having to look at high cost care and hopefully stumbling upon a root cause. You need to be able to get down to this level where you can see by individual procedure, by individual category, where are the variations. Only then are you going to be able to control costs over time. The next one that I want to show here is the oncology care, or excuse me, the enhancing oncology model. Again, similarly to bundled payments, we want to unburden patients from having to coordinate their own care. When patients are diagnosed with cancer, The oncologist frequently becomes a primary care provider in the sense that that is who the patient is seeing the most frequently, but that doesn't mean that that is appropriate in terms of coordinating care for other conditions. Um, and that's what we see here. There is a specific focus on patients with comorbidities to ensure care continuity. CMS looks at patients not just who have been diagnosed with cancer and who have had an initiating treatment, which is a chemotherapy, um, but they do want to look at patients who have chronic conditions and other comorbidities to ensure that that enhancing on how oncology model participant is working to coordinate those services with the patient's primary care provider, because the oncologist is not managing them. And so unless there is someone who is managing those conditions, there's going to be a much greater cost associated with poor outcomes and potentially hospitalizations for these patients. The program itself, again, starts with upfront investment and then bonuses or recoupment following an evaluation down the line. There are quality measures that need to be reported and administrative-based claims measures. There is a huge focus on multi-payer alignment and an emphasis on health equity. And it is noteworthy that some of the measures that are focused are end-of-life measures. There is that's one of the areas where there is unexpectedly high cost is end of life. And so that's something that the EOM is looking at. These are measures to show who received chemotherapy within the last 2 weeks of life, or patients who were in hospice for less than 3 days prior to the end of life. So we need to be able to see where those costs are coming from and to ensure that patients are have their wishes respected. And this is what you might want to see if you were looking at the enhancing oncology model. You need to be able to see the total Medicare expenditures, but then you'd also need to be able to get to some of the details and look at how much of those were related to, for example, inpatient admissions compared to your total expenditures. The next model I'd like to cover is the Transforming Episode Accountability Model, or TEAM for short. It wouldn't be a CMS program unless we had an acronym in there. This is specifically targeted for lower extremity joint replacements, surgical hip and femur treatment, spinal fusion, cabbages, and major bowel procedures. It is a mandatory model for CMS selected acute care hospitals, and it lasts for 5 years beginning in 2026. And there are 3 tracks. The first one is no downside risk for the initial year. The second track is then limited downside risk, lower track for years 2 through 5. And there's also a third track, which is a higher risk for all 5 years. And the goals are to avoid emergency department and inpatient visits or shortened stays, recover more quickly, transition back to primary care, and create equitable health outcomes. Again, you can see this is learning some lessons from the bundled payment models, where you are looking at specific surgeries rather than a whole group of them. The team measures dovetail with MIPS cost measures. You will see that as you're looking at the team measures and some of the MIPS cost measures, they are the same. And on the subject of MIPS, there are 15 episode-based cost measures. And each of them have an episode window, plus or minus 90 days from that trigger procedure either way. So you're looking at the time before a surgery and then the time after the surgery. The issue with MIPS cost measures is that as few as 10 cases can make a provider eligible for those measures. And so obviously 10 cases is a rather small sample size, and the cost component of MIPS makes up 30% of your total MIPS score. So with a performance threshold of 75 in 2024 and 82 in 2025, the importance of these cost measures cannot be overstated. This has the real potential, if you are not participating or not considered a qualified participant in another accountable care model. there is going to be the potential for uh, a large revenue shift one way or the other when we're looking at the cost measures in MIPS. So in order to determine who is eligible for that measure, it's based on that trigger procedure. Someone performed the trigger procedure, but should all costs be within that window be tied to them? No, obviously not. Not all high cost episodes are preventable. And so as you're looking at the information you receive back from CMS and as you're trying to affect the future, you need to focus on what can be controlled. It's not necessarily bad that a provider has a high cost case, because sometimes there are things that happen well beyond the realm of that procedure and episode that tie into costs. And there isn't anything that you can do about that. You need to focus on what can be controlled. Uh, MIPS is an option beyond those CMMI models. And one of the things that if you are considering MIPS, you should start looking at MIPS value pathways. It is intended to replace what Medicare calls traditional MIPS. And traditional MIPS will likely sunset by the end of the decade. And MIPS value pathways are that sort of next iteration. They are intended to streamline the four components of MIPS: the quality reporting, the cost, the promoting interoperability, and improvement activities components. Um, they are specialty or clinically relevant, and they are all tied together. It's designed to sort of break the barriers. Sometimes we see uh, people who are, there's one set of people who look at the improvement activities. There's another set of people who have been tasked with improving quality measures. And instead of having them be separate teams, the idea behind these MIPS value pathways is to ensure that there is one specific cohesive quality strategy that brings everything together. They also facilitate comparison by standardizing clinician performance. And so what I mean by that is that if there is a multi-specialty group right now, it's very difficult looking at the MIPS measures that they may report to determine anything about those specialists. They may or may not even have patients that are eligible for those measures. So if you're in a multi-specialty group and that multi-specialty group tends to report on either primary care measures or something along those lines, it's going to be very difficult to determine whether or not a specialist in that group is performing at a standard comparable to a specialist of the same type in another group. And so this helps to standardize and provide comparisons. There's also a potential future as a component for ACO quality for specialists. Medicare has floated in last year's proposed and final rules that they are considering providing extra quality points to ACOs if the providers if those specialty care providers within those ACOs report MIPS value pathways in addition to the APP reporting that is done by the ACO. This also will ensure quality payment program compliance for everyone in your organization. So not all APM participants are going to be considered qualified participants. And so by performing in these MIPS value pathways, you do ensure that nobody is hit with that negative 9% penalty that is out there if there is no QPP participation. So the last thing I want to talk about is, now that we've looked at these programs and what is out there, how are you able to create that cohesive network? The first thing that you need to do is to understand how, as a specialist, you are going to benefit from this. It's going to facilitate your success in quality reporting. That's, as I said, there is a potential for a huge downside, up to 9% of payments lost for not participating in quality reporting. It also gives the opportunity to offload primary care services and creates proper attribution for both MIPS cost and APM measures. One of the ways that Medicare determines whether or not a patient is eligible for a measure is to look at whether or not someone has provided the plurality of primary care services, and a primary care service is considered an office visit. So if you are a specialist and a patient does not see a primary care provider but sees you in the office, you could potentially be assigned to that patient in CMS's eyes, meaning that you are responsible for all of their costs, even if they have nothing to do with the scope of care that you provide. So you may be an orthopedist, but if the patient has only seen you in the office and has not seen a primary care provider, you have the potential for CMS to be looking at whether that patient's diabetes or COPD have resulted in admissions, which doesn't make any sense to you, but that's how they do it. And so by getting engaged with a network, you are able to ensure a steady stream, or excuse me, to ensure a steady stream of referrals back and forth, but then also to ensure that that you have proper attribution. You also are going to get access to episodic care insights, some of the things that you may not be able to produce on your own. And then finally, there is your demonstrable excellence can be used once you have access to those episodic care insights, can be used in negotiations with other health plans, which is absolutely going to be critical. Of course, there can't be a benefit without a bit of a balancing act. A lot of specialty groups have been able to maintain a great deal of privacy in terms of their cost and quality results. And so what will happen is that the larger network is going to need to be able to have access to some of the information that was previously limited to you. And so what you need to ensure is that there is trust in that data. That privacy and security of it is paramount. It needs to be used only for patient care. It cannot be used for other purposes in that network that you are unaware of. It is a very delicate balance, I know, but it is going to improve care and create a bi-directional referral pathway, and it is going to lead to better quality of life for the patients and also better results for you in whatever quality initiative you're participating in. So within each value-based care program, there are going to be 4 key pillars. United by several factors, patient-centered care has got to be paramount. When I say patient-centered care, I mean care for the entire patient. Finally, there is going to need to be multi-payer alignment. Again, we need to get away from different standards of care for patients who are being by different health plans, ties directly to health equity. And finally, meaningful quality and utilization measurement in addition to cost. It's not just looking at the dollars and cents. We need to see which patients are going where and why they are going. And that means looking at variations by provider and site. So if we're looking at, let's say, a certain procedure, we want to be able to see why certain providers have higher, what we call at Roji, notable observations, things that are not necessarily errors, but are high drivers of cost, so that you can identify the reasons for those variations. It may be something that is completely out of the provider's control. It could be the area in their population. It could be one facility compared to another, but it needs to be able to be visible to you front and center. Otherwise, you are not going to be able to see anything besides dollars and cents, and that is not going to give you the insights that you need to be able to control costs by affecting change. You also need to be able to investigate the root causes of high cost cases. You don't want to necessarily be focusing on that lone bubble all the way out there. You want to be able to move the entire that cluster into the lower cost range. But it is important to look at that sort of scattering out there. You want to be able to see if they are based on if there is, let's say, one facility that is in charge of these cases, one provider, or you also want to be able to see if there is a reason for, let's say, an arthroscopic procedure versus an open procedure. We've actually had clients who, when confronted with one person's much higher costs than the other, it became evident that it was because that provider was doing open procedures exclusively. And when pressed for a reason, the only answer was, that's how I've always done it. And that obviously is the kind of insight that is going to be critical to have when you're looking at including specialists in your value-based care strategy. So that takes me to the end. We are to the questions and answers.
Wonderful. And we do have some audience questions that have come in. If you do have a question that you would like to ask Dave, go ahead and drop it in now to your module. You have an area for questions specifically. We're going to get to as many as we can. If for some reason we don't get to yours today, again, someone will reach out to you via email and make sure that we get your question answered. So starting in no particular order here, first question is this: if we have a large ECQM library, are QRDAs then sufficient for a value-based care initiative?
That is a good question. The issue with QRDAs, yes, there are dozens of QRDAs, or excuse me, there are dozens of ECQMs out there, and so even though you will have a wide library of information, they're still only going to touch on patients who have triggered the quality measure in question. And so what you want to be able to do to keep your costs down is you're actually going to want to be able to see before the patients become eligible for those measures. And I'll give you an example. If we're looking at a measure about diabetes, for example, you are not going to get any of the results from ECQMs unless that patient already has a diagnosis of diabetes. Um, if you are looking at broader data collection, you're going to be able to see that a patient may be on the way, that they may find out that they have diabetes once they are admitted to the hospital for complications. So having a broader scope of information where you can see, let's say, blood pressures over time, lab results over time, they're going to give you a better idea of which patients are going to be high cost, and gives you the opportunity to intervene before that happens. And so QRDAs are, they can be helpful for quality reporting, but they are more of an after the fact piece. They're not as actionable as getting a broader set of data up front.
Great. Next question here is, are there other cost measures in MIPS besides procedural episodes?
Yeah, there are. There are a couple that are tied to chronic conditions. How much, let's say, would it cost to manage a patient with diabetes over the course of a year? And then there are a couple of global ones as well. One of those is, it's sort of a global procedure measure. It's called Medicare spending per beneficiary, and it looks at a lot of different surgical types of procedures. It's kind of a giant global episode measure. And then there is another one called TCC, total per capita cost, and that's how much does it cost to manage your average patient over the course of a year. And so both of those are actually great reasons for going beyond the QRDAs, is you want to be able to make sure that those costs, how much does it cost to manage a patient over the course of the year, you want that to be low, and that means getting to the patient before they have some sort of event that puts them in the hospital.
Gotcha. All right. Next question is, do you think the physicians are likely to avoid higher risk patients?
In terms, when I do not see a situation where CMS is going to allow patient or providers to sort of turn down higher risk patients. There are protocols in place to avoid that right now, but I do fear that higher risk patients are somewhat marginalized. You still have people saying that the non-compliant patients, as opposed to understanding what is driving some of these factors. And I think that's where a lot of the health-related social needs screenings and the social determinants of health questions are going to come into play. Is the patient, quote unquote, non-compliant because they're not taking their meds? Or do we just not know that it was a choice between a roof and medications this month?
Hmm. Yeah, it's a sticky issue. Um, okay, next question is this. Can you expand on the investment needed for infrastructure?
Yeah, absolutely. In order to be able to see that a patient is receiving the right care at the right time, you need to be able to see what has happened to that patient across the continuum of care. And so, for organizations that do not have um, that have disparate sources of data, they don't talk to each other like you would expect. There's been a huge cell of sort of magical thinking that all of this data is just going to connect, and it simply does not work like that. Patients have different medical record numbers at at each facility, sometimes within the same facility. And so you need to be able to take, let's say, a source of data from Epic and a source of data from NextGen and a source of data from Athena and whomever, and be able to ensure that the John Smith at one patient, or excuse me, at one practice is the same John Smith at another, so that you are able to track that patient across the continuum of care, understand who that patient has seen, what has happened at those encounters, and to see where there may be issues down the line. So you're going to, if you were, let's say, looking at that one of the graphics that I had shown previously, you may not know that a patient has been referred to but has not seen a nutritionist or a behavioral health specialist unless you are collecting data from multiple sources of data. It's also
Wonderful.
more timely than waiting for some of that claims data that comes back as well.
Oh yeah, for
If
sure.
you can do that frequently, for some of our clients, we're collecting data daily, some of them weekly, and so if you are collecting disparate sources of data and aggregating them within that interval, it's much more actionable.
Okay, great. All right, next question here is you've mentioned, quote, multi-payer alignment a few times. Can you say a few words about what that would look like? For example, consistent payer reimbursements on the payer side or consistent patient treatment on the provider side?
Both. And one of the things is getting away from that the varying standards of care. And so that's one of the reasons for that multi-payer alignment is you want to ensure a single high standard of care, not just for the patient, but obviously no matter what program you're participating in, if you are able to consistently demonstrate high quality and reduce costs, you're going to succeed in it. Now, in terms of payer reimbursements, yes, that is the eventual goal there as well. The idea being that you want to be able to show to payers that you are a high quality, cost conscious provider, and that you should be reimbursed at a greater rate than other people, perhaps.
Very good, very good. Uh, this next question is it may be kind of a loaded question, but I'll let you be the judge. The CBO reports that CMMI activities did not save money or improve care, and is not expected to save money in the next 10 years. How does your goal, or how does your approach accomplish this goal?
That's a great question. And the answer is that I'm not advocating necessarily that you participate in one or more of these models. However, there are key underpinnings in these models, and so that are going to save money. And I think you could tell from the lessons learned that CMS understands the same. Um, I think what I'm hoping to accomplish in this series is that you want to take some of the people who are looking at these models and designing what is going to save money down the line and incorporating them into a way that does work for you. And that means being able to get down into the details of each of these procedures, patients, etc., so that your approach is data driven rather than, I'll say, participation driven. Participating in a model is great, but unless you are truly able to get down into the details and see where there are variations in costs and quality and address them, um, it's it's um, it's kind of a checking the box sort of thing. And so what our approach is to ensure that this is able to be seen and understood, um, and not obscured behind benchmarks that are not always clear.
Very good. Well, that is all the questions that we have today. Thank you so much, everybody, for tuning in. Dave, thank you for a wonderful presentation. As we close out here, wanted to encourage you all to head over to vbcexhibithall.com. If you haven't been over there before, there's a lot of great resources and a huge archive library of all kind of different stuff, including this webinar, which will be hosted or will be archived there rather in the library. But also, we have Roji Health Intelligence has a virtual exhibit booth there. That's really cool. You could read up on them, see what they're doing in the space, and of course, there's a lot of information to educate yourself on them if you would like to reach out further. And then finally, if you would like to reach out to Dave or to the Roji Health team, feel free to do so. Their information here is on the screen. Dave or Leonard will be able to help you out, or feel free to reach out to me as well. I'm happy to facilitate an introduction if that is easier. As a reminder, this is part 2 in a 3-part series. So we're going to send out an email to everybody, and it's going to have a link to, of course, the recording from today and to the slides, but it'll also have links to where you can see the previous part 1 and to register for part 3. So that will be coming to you. But thank you all so much. Thank you again, Dave. Hope you have a wonderful rest of your afternoons.
Thank
Bye-bye.
you, everybody.